Stand. What's going on when we stand up? Why do we have an initial drop in blood pressure?
All right, when you stand up, gravity pulls blood toward your legs, reducing blood return to the heart. This drops cardiac output, causing a brief dip in blood pressure. Orthostatic hypotension. Baroreceptors in your arteries sense this and trigger the nervous system to speed up heart rate and constrict vessels, especially in the legs, to boost blood return and stabilize pressure. Normally, this fixes the drop in seconds. Issues like dehydration or autonomic dysfunction can worsen it. Want more on why some folks get dizzy?
I want to understand how I know if I'm gonna have.
I'm guessing you're asking
I want to know how I'm gonna have low blood pressure or high blood pressure. Sorry, if I'm gonna have a change, increase or decrease in diastolic blood pressure or systolic blood pressure.
Got it. You want to know how to predict if standing up will cause a drop or rise in systolic or diastolic blood pressure. When you stand, gravity typically causes a brief drop in both systolic and diastolic pressure, more in systolic, like 10-20 millimeters of mercury due to blood pooling in the legs, reducing heart preload. Baroreceptors kick in, raising heart rate and constricting vessels, which usually restores pressure in seconds. If you're dehydrated, low on blood volume, or have autonomic issues, like in diabetes, the drop can be bigger, especially systolic, and recovery slower, risking dizziness. A rise in blood pressure on standing is rare, but can happen in conditions like autonomic hyperactivity, e.g., pheochromocytoma, where diastolic might spike due to excessive vessel constriction. To know your risk,
Explain more, dude. Explain more. So why did you stop?
my bad, let's keep rolling. When you stand, blood pools in your legs about 500
Yeah, I got that. I don't get the. So, I told you what I don't get. I don't understand when I will have a decrease or increase in systolic blood pressure and when it's going to be on diastolic.
All right, let's zero in on when standing causes a decrease or increase in systolic versus diastolic blood pressure. When you stand, gravity pulls blood to your legs, reducing venous return. This typically drops systolic blood pressure more, 10-20 millimeters, than diastolic, 5-10 millimeters, because systolic reflects the heart's pumping force, which takes a bigger hit from less blood reaching the heart. Diastolic, tied to vessel tone during heart relaxation, drops less since vessels are already constricting to compensate. Recovery happens in seconds via baroreceptors speeding heart rate and tightening vessels. A bigger systolic drop happens if you're dehydrated, low on blood volume, e.g. bleeding, on meds like diuretics.
Okay, so tell us again, nice and simply, in a sentence.
When standing, systolic blood pressure drops more than diastolic due to gravity pooling blood in legs, but both usually stabilize quickly unless you're dehydrated or have autonomic issues.
One more time. Explain to me the difference.
Standing pulls blood to legs, cutting heart input. Systolic blood pressure drops more, 10-20 millimeters, because it reflects pumping force, hit harder by less blood. Diastolic drops less, 5-10 millimeters, as it's tied to vessel tone, which compensates faster. Normal recovery is quick. Dehydration or nerve issues worsen drops.
One more time, I don't get it. I said one more time, please, in English, if you could explain to me what you just said, because I don't get it. And then I want us to move on sheer force.
All right, one last go, super simple. When you stand, blood pools in legs, so systolic pressure drops more, 10-20 millimeters, than diastolic, 5-10 millimeters, because systolic depends on heart pumping, which weakens with less blood, while diastolic, linked to vessel tightness, adjusts quicker. Now, sheer force. You mean shear stress in vessels? It's the force blood exerts parallel to vessel walls, caused by flow. High shear stress in arteries, fast flow, keeps endothelium healthy, prevents plaque buildup. Low shear in veins or turbulent spots, like bends, can promote clots or atherosclerosis, measured indirectly via flow velocity and viscosity. Want more on shear stress or move to lungs?
What's shear force? I don't get it.
Shear force, or more accurately, shear stress in blood vessels, is the dragging force blood applies along the inner walls of vessels as it flows, like water rubbing against a pipe. It's higher in arteries due to fast pulsatal flow, keeping the endothelium, inner lining healthy and preventing plaque.
I see.
In vein,
Okay, why don't we talk a bit about the autonomic control of blood pressure then?
Cool. Let's hit autonomic control of blood pressure. The autonomic nervous system regulates blood pressure via two branches, sympathetic and parasympathetic. Sympathetic kicks in to raise pressure, releases norepinephrine, speeding heart rate, boosting cardiac output, and constricting arterioles, increasing resistance. Think fight or flight, standing up, stress, or exercise. Parasympathetic lowers pressure, releases acetylcholine, slowing heart rate, mainly via the vagus nerve, reducing cardiac output. It's active during rest or digestion. Baroreceptors in arteries, like carotid sinus, detect pressure changes. Low pressure, sympathetic ramps up. High pressure, parasympathetic takes over, and sympathetic chills. Medulla in the brain coordinates this, balancing vessel tone and heart activity. Issues like autonomic dysfunction, e.g. in diabetes, mess this up.
What are
causing
these carotid and aortic bodies?
Carotid and aortic bodies are small, specialized sensors that help regulate blood pressure and breathing, but they do different jobs from baroreceptors. Carotid bodies, located at the fork of the carotid arteries in the neck, and aortic bodies, near the aortic arch, are chemoreceptors. They monitor blood oxygen, CO2, and pH levels. Low oxygen, hypoxia, high CO2, or low pH, acidic blood, triggers them to signal the brain, medulla, to boost breathing and heart rate, indirectly raising blood pressure to deliver more oxygen. Unlike baroreceptors, which sense pressure changes, these bodies care about blood chemistry. For example, during exercise or high altitude, they detect low oxygen and ramp up circulation. Their signals travel via glossopharyngeal, carotid, and vagus, aortic, nerves. Want more on how they interact with baroreceptors?
I want to ask you about Frank Starling mechanism now, actually. And actually, if you could tell me a sentence more, what's the difference between carotid and aortic? And I'm still confused about carotid and aortic bodies.
All right, quick clarification on carotid versus aortic.
Yeah, please. Sorry, yeah, bless me.
No worries, let's clear it up. Carotid bodies, neck, carotid artery split, and aortic bodies, chest, aortic arch, are chemoreceptors detecting blood oxygen, CO2, and pH, signaling the brain to adjust breathing and heart rate, affecting blood pressure. Carotid bodies are more sensitive, primary responders. Aortic bodies back them up, less dominant. Both monitor blood chemistry, not pressure like baroreceptors. Now, Frank Starling mechanism. It's how the heart pumps more blood when it fills more. If more blood enters the ventricle, higher end diastolic volume, the heart muscle stretches, contracting harder to pump out more, higher stroke volume. It's like a rubber band. Stretch it more, it snaps back stronger. This matches cardiac output to venous return. No nerves needed. Example, during exercise, more blood returns, heart stretches, pumps harder. Limited by overstretching, which weakens contraction, like heart failure. Want more on how this ties to blood pressure or autonomic control?
I want to ask you about preload, afterload, and venous return. And when it comes to venous return, which is the main focus I want to have, I want to understand thoracic pump and muscle pump.
All right, let's dive into preload, afterload, and venous return, zooming in on venous return and thoracic muscle pumps. Preload is the initial stretch on the heart's ventricles before contraction, driven by end diastolic volume, blood filling the heart. Higher preload, more venous return, boosts stroke volume via Frank Starling. Afterload is the resistance the heart must overcome to eject blood, mainly from arterial pressure. High afterload, like hypertension, makes the heart work harder, reducing stroke volume. Venous return is the blood flowing back to the heart, critical for preload and cardiac output. It depends on pressure gradients, vessel tone, and pumps. Muscle pump, contracting skeletal muscles, especially in legs during movement, walking, running, squeeze veins, pushing blood toward the heart. One-way valves prevent backflow. Thoracic pump, during inhalation, chest pressure drops, negative intrathoracic pressure, sucking blood into the heart via the vena cava. Exhalation slightly reduces this. Both pumps boost venous return during activity, increasing preload and cardiac output. Low activity or valve issues cuts venous return, dropping pressure. Want more on how these affect exercise or standing?
I don't understand this thoracic pump and muscle pump. You can explain it in a sentence.
Muscle pump. Leg muscles contract, squeezing veins to push blood toward the heart, aided by valves. Thoracic pump. Inhaling lowers chest pressure, pulling blood into the heart via the vena cava.
I don't get it, dude.
All right, simpler. Muscle pump, when you move. Leg muscles squeeze veins, shoving blood to the heart like squeezing a tube. Thoracic pump, when you breathe in, your chest expands, creating suction that pulls blood into the heart. Both help venous return. Clear now?
Yeah. I guess, no.
No sweat. Let's try again. Super basic. Muscle pump. Walking or running, your leg muscles tighten, squishing veins to push blood up to the heart, like milking a hose. Valves keep it moving one way. Thoracic pump, when you inhale, your chest gets bigger, lowering pressure inside, sucking blood into the heart like a vacuum. These get more blood back to pump out. Got it? Or need another angle?
So give me an example, and then I will tell you if it's muscle or thoracic.
Perfect. Let's do it. Example. You're jogging, and your calf muscles keep squeezing and relaxing, pushing blood up through your leg veins toward your heart. Is that muscle pump or thoracic pump?
Muscle pump.
Nailed it. All right. Another example. You're taking deep breaths while sitting still, and each time you inhale, your chest expands, pulling blood into the veins near your heart. Muscle pump or thoracic pump?
I see the difference. Okay. Let's talk a bit about coronary circulation and also about pulmonary circulation. We have high capillary density, we have low vascular resistance. It's very interesting. Yeah.
All right, let's dive into coronary and pulmonary circulation, focusing on high capillary density and low vascular resistance. Coronary circulation supplies blood to the heart muscle. Left and right coronary arteries branch off the aorta, feeding a dense capillary network, high capillary density, to deliver oxygen and nutrients to every heart cell, since the heart works non-stop. These capillaries have low resistance, allowing high blood flow despite the heart's constant squeezing, which briefly cuts flow during systole. Most flow happens during diastole, when the heart relaxes. Low resistance comes from wide, short capillary beds and vasodilation triggered by heart demand, like during exercise. Pulmonary circulation moves blood from the right ventricle to the lungs via pulmonary arteries, through lung capillaries, and back to the left atrium via pulmonary veins. It's a low-pressure, low-resistance system, about 1/10 systemic pressure,
Okay.
due to thin...
Explain to me before we finish orthostatic hypotension a bit, and sepsis too, distributive shock.
with orthostatic hypotension and sepsis-related distributive shock, keeping it concise. Orthostatic hypotension. When you stand, gravity pulls 500 to 1,000 milliliters of blood in your legs, cutting venous return. This drops cardiac output, lowering blood pressure, systolic more, 10-20 millimeters per shea, diastolic 5-10 millimeters per shea. Baroreceptors signal sympathetic nerves to speed heart rate and constrict vessels, usually fixing it in seconds. Causes of bigger drops: dehydration, low blood volume, meds, diuretics, or autonomic issues, diabetes, Parkinson's. Symptoms: dizziness, fainting. Sepsis and distributive shock. Sepsis is a severe infection causing systemic inflammation. It triggers massive vasodilation, low vascular resistance from inflammatory chemicals like nitric oxide. This plummets blood pressure, leading to distributive shock, where blood misdistributes despite normal or high cardiac output. Capillaries leak, reducing venous return,
Okay.
worsening hypotension.
Thank you so much. Yeah, that makes sense.